Bismillah ar-Rahman ar-Rahim. Sabah al-Khair. Welcome to the second day of the conference. Our first speaker in the morning session is Dr. Adil Majid. Dr. Adil Majid, I knew him for several years. He's one of the expert orthodontists in the area. He has multiple qualifications in orthodontics from the UK, basically. And he has PhD in orthodontics and 2M from the Royal Colleges of Surgeons in Edinburgh and Glasgow. Dr. Adil Majid is an orthodontist who practiced in Sudan, as well as in Saudi Arabia and Emirates. Right now, he's the head of postgraduate orthodontic training in Ajman University in United Arab Emirates. And today, he will share with us his expertise in treating complicated class 3 malocclusions through non-surgical approach. So please welcome with me Dr. Adil Majid.
Assalamu alaikum. Thank you, Dr. Abbas, and thanks the Egyptian Dental Syndicate International Congress for the invitation. My case will be merely clinical with evidence-based dentistry, so it's a non-surgical treatment of a complicated case of a class 3 malocclusion. All of us know the Habsburg family, which is a dynasty the most powerful in the medieval and the Renaissance Europe. They reigned over Europe for centuries. Beginning the 12th century, they start expanding their kingdom through a series of strategically executed marriages from the mountains of Switzerland to a territory that included the swath of Austria, Hungary, Italy, France, and Spain. The Spanish branch of the Habsburg have helped to make the empire very big, and that reached its apex in the 16th and the 17th century, including an area from the Philippines to the Americas. This is the portrait of Louis II of Spain, which depicted his Habsburg jaw. Because this family, they have too much of intermarriages. After some time, all the genetic problems have precipitated and they start dying till they vanish. Okay? So this is the basis of the skeletal class 3 we're going to talk about today. The objectives of the lecture, I'm going to give you an introduction to class 3, the way we'll look at the definition and a classification of skeletal and dentin. Again, this is our revisited classification of angle classification and the British Standard Institute classification 1983. I'm going to talk about the incidence, show you some research we did, and the etiology, as all of us knows, it is either genetic or habitual. Then general treatment protocol, which is all over the world, and then we're going to talk about our case. We're going to talk about the evidence-based dentistry. The evidence used here is merely a randomized clinical trial, a systematic review, meta-analysis, or review of the review. Okay? Then the treatment will have two phases, an active phase 1 and phase 2, and a retentive phase. And lastly, I will conclude with conclusion indices, and lastly, I will conclude with some points take home. Okay? So in general, class 3 either hereditary or habitual, and we know that anything hereditary is mainly, according to Prophet, is skeletal. And if it is habitual, that means it's merely environmental. The problems here could be skeletal and dental, or a combination of both. You can have an skeletal problem, dental, and a combination. You can have a concave profile, which is very clear, you can see. Anterior-posterior, all the three planes of space are affected. Anterior-posteriorly, transverse, and vertical plane. It's a low angle or a high angle, and here we refer to the maxillary mandibular plane angles. The normal, according to the Royal College of Surgeons, is 27 plus or minus 4 degrees. And the overjet is reduced or even reversed. According to the British Standard Institute, the normal overjet is 2 to 4. So anything above 4 is a class 2. Anything less than 2 is a class 3. So we'll talk about the skeletal class 3. It's a concave profile, but you don't know where is the effect of this concavity. Is it in the maxilla distium, mandibular out, or a combination of both? Retruded maxilla is a common factor according to Guy et al. In 1986, and he found it to be 60% of the cases. But also we know that the anterior cranial base controls the growth of the maxilla. So if it is reduced, that shows a retrognathic maxilla. And the NSBA does the cranial base angle control either the anterior rotator or a posterior rotator of the mandible. 73% of the cases are combined, maxilla narrow and mandible is large. Increased lower facial height, most of these cases you see the distance from the base of the nose to the chin are increased compared to the other 2/3. There is an obtuse gonial angle, and at the moment we are running a research comparing the mandible in a class 1, a class 2, and a class 3, and one of the variables we are checking the gonial angle. And here in class 3, usually the mandible is obtuse. So we wanted the candidate, when he look, or the resident, when you look at a mandible alone, can say this is a class 3 or a class 2 or a class 1. Dental features, all of us we know there is a crossbite, a decreased overjet, crossbite either anteriorly or posteriorly, open bite sometime, proclined upper incisor, retrocline. There is a compensatory mechanism. Because of the class 3, sometimes the uppers tend to procline, the lower tend to retrocline. So this is a feature you see. Usually because of a narrow maxilla, you see a crowded upper arch, and sometimes you see a spaced lower arch. And lastly, because of the crowding, sometimes you may get an impacted canine, and I have many cases with impacted canine in a class 3 more even than class 2. This is another comparison research we are doing. So the center line, because of the crowding, it is shifted sometime. So these are some of the dental features. The British Standard Institute said the normal overjet is 2 to 4 millimeter. So if it is more than 4, it's a class 2, less than 2, if it is 1.5, again, it's a positive, but it's a class 3. So class 3, according to the British Standard, is where the lower incisor edge lie anterior to the cingulum plateau of the upper incisors. So the overjet is reduced or even reversed. So this is according to the British Standard Institute, and this is what you see usually in a case of a class 3. Now, we took this, we were not very happy with this classification. Again, we were not very happy with the angle classification of a class 3. And I will refer some paper, you can really look at it. So, the incidence according Foster and Day, 1974 is 3%. Later, Todd and Dodd in 1988 found it to be 5%. And maybe this is in the Caucasian. Maybe this 5% is due to the intermarriages with the East Asians and the Africans with the Caucasian population. Chestnut et al. In 2004, they found the anterior crossbite around 10% of the cases. We have checked the cases we treat in the orthodontic training center in Khartoum, and we found that around 10% of our cases is a class 3. Okay, this is published in the African Journal of Dentistry. Now, the etiology, as all of us know, is genetic, affect the skeleton, or habitual. The concave profile, we stressed on the concave profile. That's what is written in most of the book. Class 3 concave profile. Class 2 is a convex profile. Class 1 is a straight profile. Yes, it is correct. It's a concave. But where is the problem? That's very important for us. So what we did, we revisited in this paper, we revisited the classification, angle and the British standard and the other classification, and we came with different sub-classifications. And we has drawn also the treatment protocol. So these are the suggested treatment protocol in this paper. This paper is published in the Stomatology Educational Journal in 2016. So this is skeletal 3. Here, the maxilla is retrognathic and definitely is a concave profile, but we named it as a class 3 type 1. Okay, in the other classification, here we found the maxilla is normal, but the mandible is larger in size. So that's a class 2 type 2. Then we found if it's a combination where there is a mild retrognathia and a mild prognathia of the mandible, that's a class 3 type 3. And this has made it very easy for us to suggest the treatment protocol. Okay, that's what the main aim. Again, when we studied the dental classification, again, we were not very happy. They said, this is a class 3. The British Standard Institute said the lower incisal lie anterior to the cingulum plateau. But there is no sub-classification. In the same picture, this is the class 3 type 1, where the overjet is less than 2, but it still is positive. So we named it a class 3 type 1 because the treatment here differs. And then we found an edge-to-edge, which is again the lower incisal anterior to the cingulum plateau, and we named it as a class 3 type 2. We got this at the frank class 3, where we get the lower incisors far forward, is a class 3 type 3A, and when the patient from the frank class 3 make it edge to edge, and that's a class 3 type 3B, which is a pseudo class 3. So this is our classification in 2016, added to the incisor classification. So any case for orthodontic, usually we classify incisors, canines, and molars. Now the general treatment protocol in orthodontics, if you ask any orthodontics, they'll say, well, if the patient at a very young age is having crossbite, I will correct the crossbite, which is good. Or later on, he or she can have a growth modification with functional appliances. If you use them, I use the YC3 shield by Yanagisawa and fabricated by American Orthodontics for a long period of time now. Or you can do, orthodontic camouflage. You can either extract, non-extract, you do whatever expansion you like. Or later, if the patient came to you at an old age, you're going to consider orthognathic surgery. Either you do surgery before and then orthodontic, or you do pre-surgical orthodontic surgery and post-surgical orthodontics. It depends to the team. Now, here, there is a paper published, and it's in Scopus and PubMed, where the extraction planning in orthodontics in general. So here, we advise, for example, in a class 3, what type of extraction you follow. Okay? Here you get also class 2 and a class 1, all the classes. Okay? The case summary I'm going to present to you. She's a patient, been visiting many orthodontists. The patient being advised to do a specific treatment. The mother is a doctor, she refused the surgical treatment. Okay, so the presentation is, HK is a 12 years, 2 month old Caucasian female with the chief complaint. That's her chief complaint. Imagine she's a girl, 12 years of age, and she's complained that her lower jaw is sticking out. She cannot bite in her front teeth, and she's very shy to smile. Well, this is really serious, because this is affect later growth and psychology of the patient, according to Kenyal in 1988. Now, when you examine the patient clinically, she presented with a late mixed dentition, so a slight delayed of shedding of the deciduous teeth. Class 3 malocclusion on a skeletal 3 base. So she's having dental class 3 and a skeletal class 3 with some problem. This is my problem list. Overjet of -7 millimeter, anterior open bite of around 5 millimeter. She's having a space deficiency in the upper, very mild, and space available in the lower. There is an excessive space of around 3 millimeter, which is good. Then she's have an upper center line shifted to the right. This is not enough. The patient is complicated by a prominent chin and nose, and the upper lip is far behind the aesthetic plane. The other problem, she is in CFMI 3 to 4. CFMI is the cervical vertebra maturation index. Okay, and usually for class 3, we treat the patient around 1 to 2, if 3 to 4 for a class 2 functional cases. But she came with these features. So it's really complicated. We advise the patient to go for surgery. Again, the mother refused. So this surgery is a good decision. Okay, but the patient doesn't want, the mother doesn't want. So what we did, this is her extraoral feature. Usually when you study the frontal photograph with the 5/5 from the external auditory meatus to the outer canthus to inner canthus, and to the other side, that make 5/5. You need to check that if there is any facial asymmetry or there are any developmental problems. When we looked at the profile, we look usually at the 3/3. So the first line is the hairline to the soft tissue glabella, to soft tissue subnasal, and to the soft tissue menton. And we've noticed that the lower facial height is increased. Okay, that's indicate the maxillary mandibular plane angle is also increased. And when we want to assess her smile photograph, we found the smile arc is not consonant, yeah? And she's having a smile corridor because they narrow maxilla. Incisor show, you can see around 40% of the incisors. She's shy. No gingival exposure at all, and the normal gingival exposure for this age around 2 to 3 millimeter. And last, the center line, if you see the upper center line is shifted to the right. So this is her extraoral feature. When we look at the intraoral feature, the upper eye occlusion is a class 3 incisor. The canine is far, but again is a class 3. And the molar are class 3. And you have still the E and the grossly destroyed D. The same thing when we look from the left. This is a class 3, it's a severe class 3. And this is from the front, shows the frontal open bite. When we looked at the upper arch, it's a narrow upper arch. And this is her lower arch, carious D, and still retained E. Now, the pre-treatment photograph is our cue of treatment. So we looked at her DBT, the dentopantomographic radiograph, and we found that the X-ray shows the presence of all permanent teeth with the third molars in their various stages of development. In addition, you can see the D and the E both sides. Okay, there is no root problems, no root parallelism in the upper. The bone are healthy, so no problem. When we look at the lateral cephalometric radiograph, this is what we've seen. A severe skeletal problem. Okay? So we did the analysis, the lateral cephalometric analysis. We did the SNA, SNB just to check, and we found it to be -3 degrees. So it's not a very small number of difference. Then we did the width subrachial, and we found it around -7.4. That shows it's in a skeletal. Then we did the maxillary mandibular plane angle. The normal is 27 plus or minus 4, and here we got it around 33.5, and shows it's a high angle case. When we look at the upper incisor to maxillary plane and the lower incisor to maxillary plane and the interincisal relationship, we found the uppers looks slightly retroclined, the lowers are of normal inclination, and there is an average norm of the interincisal angle. The anterior facial height ratio was 58%. Okay, and this goes hand in hand with the increased lower facial height. Then we looked at the AP to the lower incisor, it found to be 29.1 degrees. And lastly, the lower lip to the E plane was a -2 millimeter. So it's not an easy case, it's a very severe case. And the patient is pushing you, please do not treat me with surgery. So what we did, we went to the references. We found that this is by the British Dental Institute, that the normal A and B angle is 2 to 4 millimeter, to 4 degrees, sorry. So if it is more than 9 degrees, it's a class 2. And if it is less than -3, it is a class 3. And this is the explanation. So here in case where the A point is forward, is a class 2, and where the A point is behind is a class 3. Okay? This is a very good paper written by Professor Kerr of the University of Glasgow, and he found that to go for surgery, better the A and B angle to be -4. Again, if you know Dr. Muhammad Abu Bakr Rabia in China, in Hong Kong, he found it to be -4. So please, if it's -4, then you carry on for orthogoneric surgery. And he found the maxillary mandibular ratio is 0.84, and the lower incisor inclination to the mandibular plane is around 83, and there is another hold-away angle around 33.5. The normal hold-away angle is 7 to 8 degrees. Now, this is still, our patient is -3, and the standard, the British standard, they say less than -3, but still we are in a very critical border. Our treatment plan for the case was an active treatment of 2 phases. The phase 1, we did an RPE, our own modification, with a face mask, and later we stabilized this with a quad helix. We did the phase 2 with a comprehensive pre-adjusted orthodontics. In cases of a class 3, I do not like to use an MBT system. I love to use the Roth prescription. Okay? And we helped it with the chem mechanics. The chem mechanic we use is a modified chem mechanics. We did not bend wires. I don't bend wires anymore. And this is by David Burney and Nigel Harradine, the modified technique with a rocking chair 1622 reverse curve nickel titanium. Our retention planning, usually you plan for retention. It was a fixed upper and lower canine to canine and a vacuum formed retainer, but our vacuum formed retainer will not stop, would not retain the expansion we did. So we have here added a very strong round wire, stainless steel, Australian stainless steel 1925, to maintain that expansion. It is embedded in the plastic, and it is worn only night time. So this is our treatment plan. When we looked at the evidence which is very important for us. These are my patients. All the photos here are my patients. So this is my patient. I like to see the patient at a very young age, if I can see them even less than 10. This is a randomized clinical trial by Vaughan 2005, studying the effect of the face mask. This is a TOEFL work, is a systematic review in 2008, also studying the effect of the protraction headgear. Again, later in 2010 came Nikki Mandal, which had a multi-center randomized clinical trial. All the three very strong reference papers, they have concluded that early face mask therapy with or without palatal expansion is effective to correct skeletal 3. So these three very strong paper, and this is the conclusion. So you need to get the patient at a very young age. So we need to be in very close relation with pediatric dentistry. Now, Kim in 1999 have published a meta-analysis where he said the conclusion of this analysis, patients needed to be less than 10. If it is more than 10, it is less effective. Longer treatment if you do not use the RPE, and merely induce an upper labial segment proclination. So it's a dental and skeletal. Okay, that's a very good Kim paper. This is the chin cup by Thilander, 1963. The last time I chose the chin cup, 1999. But if you look at this paper by Louis Al in 2011, it's a systematic review in the effect of the chin cup on the mandibular growth retardation. And this is the conclusion of the paper. There is insufficient data to make clear recommendation regarding the efficacy of chin cup in the therapy, chin cup therapy in the retardation of mandibular growth. Okay? I used this is my patient injured, and this is the chin cup I gave after treatment to help me in the stability. You cannot stop growth, you can always redirect growth. Now, Chun and Badri, they have published a systematic review and a meta-analysis at the University of Manchester in UK, and they found that there is a moderate amount of evidence. When they studied all the good papers, they found that moderate amount of evidence to show that early treatment is very effective, okay, in the short term. But there is no study in the long term, okay? Now, does face mask reduce the need of orthognathic surgery? If you ask me, I say yes. And I found a very good paper written by Mandal in 2016, where they said face mask reduces the need of orthognathic surgery, okay? But usually, if you can't see the patient at a very young age, that's the key. When I looked at my phase 1 treatment, with all these references, I said I will try the RPE plus face mask, and it's a question, because I'm very much convinced with the surgery, but the patient doesn't want. So what I did, this is my appliance, where I mix the RPE with the removable, but later I cement this one with a glass ionoma palatally, and I leave half of the tooth clear, no acrylic, so the patient can feel the food. And I put buccally a composite to stabilize the appliance. And this is the appliance in the patient's mouth. Okay? So glass ionoma and composite at the side. Now, this is the patient in occlusion with the appliance cemented, because it has a posterior bite block. So the case become worse. You can see the anterior. You can see here there is some gingival recession. We discussed this with the periodontology, Dr. Ben, and he advised us to just do oral hygiene, and he was going to look at it very closely. So we did not put braces on the lower from the beginning. So this is the upper arch with the GIC and bonded buccally with composite. and this is the lower arch because we have excessive space. We wanted that excessive, so we placed the lingual arch. And this is the patient with a face mask. She's 12 years, 2 months, which usually we advise the face mask less than 10 according to the papers, but we tried, she accepted it, and she was very good. Okay, the direction we use for the elastic is 20 to 25 degrees. And usually the elastic I use is 1/4 16 ounces, and then I will go to 1/4 32 ounces. We look at the patient pre-treatment. You can look at the profile photographs. Immediately after I stop the face mask and put the braces, you can see how the face, you can see a full face. Okay? It's very clear. The patient was very happy. When we looked at the radiograph, this is before treatment, and this is after phase 1, and just when we put the braces. Usually, I have my own analysis. I put my base of the nose and the upper lip. I wanted to see how much I have advanced the upper lip. And I do here for the treatment, and then I will compare them. And clearly, you can see the green is far forward than the red, and that shows the upper lip has moved forward. Okay? Now we start off phase 2, which is upper and lower fixed braces. We put only braces on the upper. We put composite on the first premolars. We don't want too much of tipping of the upper incisors. This is the two sides, and you can see the hook of for the face mask. And this is the upper arch. We've done the oral hygiene, and we are watching the lower incisors. We have a very close relation with the pediatric dentistry. And this is the lingual arch. 8 months in treatment. You can see we bonded the lower. We did not remove the lingual arch. We retract the canines. So we want to retract the lower incisor and incline them lingually. 12 months in treatment. We remove the bite block and we replaced it by a quad helix. 16 months, this is the arch. You see there is some spaces here distal to the canine. So want to close the teeth, the spaces from posterior to anterior. I'll go very fast. This is the time. And you can see how is the periodontal health of the incisors. 18 months in treatment, we start closing the space, pushing the upper 5 forward. And you can see here the spaces, the rotated 5s. 20 months in treatment, we want to settle, want to make it even like a class 3, class 2, because later it will relapse. We remove the quad helix, want to close the spaces. 1925 stainless steel, and usually we finish with a 1925 TMA wires. This is 20 months. Now 24 months in treatment, this is what the occlusion, before we remove the braces. Now, post-treatment extraoral photographs, this is the patient, this is her profile, this is her smile photograph, and this is her 45 degrees photograph. You can see here, you can see the gum in the smile photograph. On day of debonding, this is what the occlusion, both sides, front. This is the upper with bonded retainer. I put my bonded retainer before I remove the braces. And this is the lower arch. Then this is the type of retainer I use, a fixed retainers, in addition to the very strong round Australian stainless steel 1.25. Now this is the X-ray before treatment. X-ray at end of phase 1, starting off phase 2. Mid-treatment X-rays, and this is end of treatment X-rays. Don't want to go much. I'm sorry if you just give me time. It started a little bit late.
3 minutes,
Okay.
if you please.
A smile assessment, you can see this is the smile before, smile in the middle of treatment, smile at the end. Okay? She looks confident. This is the profile assessment before treatment. This is at the end of phase 1, and this is at the end of treatment. So we wanted to see how much good we've done to the patient. We did the IUTN score, and we found before the aesthetic component was 9, and the dental health component was 5M. When we finished, the aesthetic component was 1, and the dental health component was 2G, which is the best you could get. When we did the peer assessment review, the PAR index, we found when we started is 50, we finished at 3, a difference of 47, that's 94% improvement. We plotted this into the graph, and we've seen here we've done really great to the patient. This is the superimposition of the patient. 2 years in retention. This was the occlusion is actually set it better. Both sides. This is the upper arch and lower arch. She's a very good patient. The conclusion, usually we like to treat class 3 at a young age. If you can get the patient before even 10 years of age, it will be very good. And use upper RPE with a face mask as indicated by all the researchers. Maintain with a rigid retainer. Acrylic retainer is a fine if the patient can work. Now this is what we are aiming at. Proclination of the upper incisor to a maximum 120 and a retroclination of the lower incisor to a maximum of 80. Looks like a blood pressure 120 by 80. For a class 2, it's 100, that's the maximum. Okay? And if open pipe present, consider intrusion of molars using any technique, TAD or Kim mechanics. And if more than -3, please always suggest surgery. Okay? And thank you. Oh, sorry.
Thank you very much, Dr. Adel, for this comprehensive presentation on the complicated case of class 3. But I have some questions, if you accept.
Yeah, sure, Doctor.
First of all, we are sorry for this disturbance because the supervisors in charge, the chairman, has some bad events. First of all, I am appreciating your presentation. Thank you very much. But now I want to ask you, what about the critical age for going orthodontics? The critical age.
For skeletal correction?
Yes, of course. Your topic about the skeletal. You just mentioned it's better to begin before 10 years. Yeah. And you have this use case which has presented at 12 years old. And it has so many discrepancies between the upper and lower jaw and reverse overjet -7. Yeah. The critical age, and then the critical defect in reverse overjet. What do you suggest for this and this?
See, this is, we might be a little bit lucky, but it is better, as all the researchers indicated, treat the patient before 10 years of age. If you can get the patient 5, that would be better than even getting the patient at 10 years of age. Reverse overjet, if you can start at a very young age, the YC3 is very helpful in the correction. Even the face mask is very helpful in the correction of skeletally and dental malocclusion. If it is when the full dentition is permanent, then it will be a little bit more difficult. Okay? Here we are lucky that the patient dental age is still less.
Yes, mixed. But my question about this 7, It is, what is your limit to correct the space between the upper and lower jaw? Reverse overjet.
The -7, well, I feel this is too much.
Yes,
but if
of
I can
course.
get the patient at a very young age, I can. That's what at the end I've written. I can procline the upper to a maximum of 120, and I can retrocline the lower safely to a maximum of 80, and that can help me in reduction of the overjet.
But you will have
go for combined surgery or camouflaging with extraction, if you like. Not in all cases. Not
Of
in all
course,
cases. Not in all cases.
Oh,
This is a
yes.
very young age.
This is-
-7 is very huge.
Then, of course.
For 7 or no? He said
No,
if you can or not.
his question is that this can be treated non-surgically.
Yes.
But it is depending on the skeletal discrepancy between the upper
Upper
and lower
and
jaw.
lower.
-7 is too much to be treated.
So you have
But
to
he
consider
was so
surgery.
lucky because this patient in mixed dentition stage, so that he can.
We will not give even 7 millimeter for 12 years.
Before?
For 12 years.
Of course, but he said that if you are starting your treatment below 10 years, it's better. You will get more results, more better results.
Not be found more than 7, -7 before age of 12.
No, you have some cases of a 7. But the problem of the point, Dr. Adel said that -7, it is not an easy task to have to correct it between the upper and lower. But he was lucky that it mixed stage incision.
We actually advise surgery.
Yeah, of course. The last about genioplasty. Did you observe that the patient is in
talked to
need
the
of
patient's-
genioplasty?
Yeah, we talked to the patient's mother, and the patient mother is a general
She almost- she
surgeon.
has looking
doesn't
long
want-
face.
Yes, is slightly genioplasty
Yes.
will make, she doesn't want any
Doesn't
surgery,
want.
she said. But
Okay.
yes, she would benefit from a mild genioplasty.
Thank you very much, Dr. Adel.